So I'm Ben Miller. I'm presenting the laparoscopic versus robotic inguinal hernia repair, the 1 and 2 year outcomes from the RIVAL trial. The RIVAL trial involved 8 surgeons from 6 institutions. These are our disclosures. The RIVAL trial was funded by an unrestricted grant from Intuitive, and 6 of the surgeons in the trial received fees from Intuitive Surgical. So robotic inguinal hernia repair has some perceived advantages over laparoscopic inguinal hernia repair, namely its wristed instruments, which allow for multiple degrees of freedom, and its enhanced optics with a high-definition 3D laparoscope. And robotic inguinal hernia repair has grown exponentially over the last few years. This is a study from a group that looked at the Michigan Quality Collaborative and found that robotic inguinal hernia repair increased 41-fold from 2012 to 2018. But only one study has ever compared robotic to laparoscopic inguinal hernia repairs head-to-head, the RIVAL trial, whose early results were published in 2020. The RIVAL trial was a randomized clinical trial that compared robotic to laparoscopic transabdominal preperitoneal inguinal hernia repairs. Included patients who were at least 21 years old with a BMI less than 40 and a primary or recurrent unilateral inguinal hernia. All the surgeons who participated had completed at least 25 robotic and 25 laparoscopic procedures, and they all also happened to be fellowship trained in minimally invasive surgery. The entire operation was performed by the staff surgeon. In all cases included a piece of heavyweight 10 by 15 centimeter polypropylene mesh. For the laparoscopic repairs, the mesh was fixated with tacks and the peritoneum was closed with tacks. For the robotic repairs, the mesh was fixated with suture and the peritoneum was closed with suture. 102 patients were randomized, 54 to the laparoscopic arm and 48 to the robotic arm. These are the early results of the RIVAL trial. So we found that the robot was associated with greater total cost per case and longer operative times, but both repair approaches had similar pain scores at 1 week and 1 month. The robot was also associated with greater surgeon frustration as measured by the NASA TLX instrument. Okay, so those are some of the early outcomes. Now let's look at some of the long-term outcomes, the 1 and 2 year outcomes of the RIVAL trial. So we assessed pain, neuropathic pain, quality of life, physical activity, wound morbidity, and hernia recurrence. Pain was assessed with the visual analog scale, which measures pain on a scale from 0 to 100, where 0 is no pain and 100 is the worst possible pain. Neuropathic pain was assessed with the Leeds Assessment of Neuropathic Symptoms and Signs pain scale. And although this is a scale, you get a dichotomous outcome. So scores less than 12 indicate no neuropathic pain, and scores over 12 indicate neuropathic pain. Quality of life was assessed with the 36-item short-form health survey, which assesses quality of life as it relates to physical and emotional functioning in these 8 domains. Lower scores are worse quality of life, higher scores are better quality of life. Physical activity was assessed with the physical activity assessment tool, which looks at moderate and vigorous physical activity in 4 areas of physical activity, and it's measured in minutes per week. Hernia recurrence was defined as either a bulge on physical exam or a patient-reported bulge. And the patient-reported bulge was detected using the hernia recurrence inventory. Question number 2, do you feel or see a bulge? Has a high sensitivity for detecting inguinal hernia recurrence. 102 patients were initially randomized, 54 to the laparoscopic arm and 48 to the robotic arm. We had pretty good follow-up, I'd say. At 1 year, we had 81% follow-up, and at 2 years, we had 75% follow-up. These are the pain results. So the y-axis are the VAS scores. Lower scores indicate less pain, higher scores are more pain. The y-axis, or the x-axis, y-axis is VAS, x-axis is the time. And you can see that both repair types, the pain improved from baseline and was similar at 1 year and 2 years. And no patients in either treatment arm experienced neuropathic pain. These are the quality of life results using the SF-36. So these 8 domains of physical and emotional functioning on the left, there were no significant differences between robotic and laparoscopic inguinal hernia repairs at 1 and 2 years. There were no differences in quality of life between the 2 repair approaches. This figure represents physical activity. So the y-axis is the activity in minutes per week, and the x-axis is time. And these 3 boxes denote moderate, vigorous, and moderate plus vigorous physical activity. And again, there were no significant differences in physical activity between the 2 treatment arms at 1 year or 2 years. There was no wound morbidity experienced by any patient, and there was 1 recurrence in the laparoscopic group and 1 recurrence in the robotic group. So for surgeons who have experience in minimally invasive inguinal hernia repair, the outcomes between laparoscopic and robotic inguinal hernia repair are similar at 1 to 2 years. And if you're already proficient in laparoscopic inguinal hernia repair, adopting the robot for inguinal hernia repairs does not seem to offer an advantage. That's it. Thanks.